Stuart McLean. I co-head our health systems service line, and I'm delighted to welcome you to our second panel, Health Systems in the COVID Era. During the next 45 minutes, we'll hear from our prominent and innovative health system leaders who have been based really at the very center of this COVID crisis. Today's panel will be structured as 2 or 3 sets of questions for discussion by our guests, and time permitting, we'll take a question or 2. Our panel will be led by Dr. David Shulkin, the 9th Secretary for Veterans Affairs and an A&M Senior Advisor. With that, thank you, David.
Hey, thanks so much, Stuart. This is actually one of my favorite meetings, the A&M annual meeting. Over the past 15 years, I've come to the meeting and spoken at it several times. It's usually associated with some type of big hurricane that hits down at Kiowa, so I don't mind doing this one virtually. But we couldn't think of 3 better people to join us today on the panel in the midst of a national pandemic, social unrest. Steve and I are in Philadelphia where we're having rioting right now, an economic upheaval, and on the most divisive eve of an election that we could ever imagine. So I can't wait to hear what they're going to say. And I'm going to ask for the 3 panelists to forgive me up front because I'm not going to be able to give them proper introductions because we take up all the time telling you about them. Let me just say that all 3 are physicians. All 3 are considered rock stars in healthcare leadership. All 3 are people that I personally have a great deal of respect for, and I'm proud to call all 3 of them my friends. So let me just briefly introduce them so that you have a sense about who they are in my sort of informal way. I'm going to start alphabetically with Dr. Steve Klasko. Steve's been the CEO at Jefferson Health since 2003. Where he's really led the transformation of that system. It was considered, prior to Steve's arrival, a very conservative, sleepy system that frankly played second fiddle to the University of Pennsylvania. But today, it's a very different organization. It's a dynamo organization. He grew it from 3 hospitals to 14. He added international campuses, a university, a basketball team, and even a marijuana-based clothing company. When you take a look at Steve's bio online, it has a big flashing warning sign saying by the time you read this, it's probably outdated because he is involved in new stuff every day. And his perspective on healthcare is very different, as I think you're going to see. He keeps writing books to explain what healthcare is about to the rest of us. First, he tried it through science fiction. Then he wrote a children's story to explain it. And last, he actually wrote it with a venture capitalist. So keep at it, Steve. He's a remarkable executive, but his real talent is being a DJ and spinning records. Paul Rothman has been Dean of the School of Medicine at Johns Hopkins University and CEO of Johns Hopkins Medicine since 2012. Prior to that, Paul had been Dean at the University of Iowa. Ever since he was a kid, he was interested in math and science, which may explain why you go to MIT and why you grow up to be a clinician scientist. The area that he studies, which I would have thought would have been really boring, was cytokines. Now, of course, that's the rage with what's going on with COVID-19. So having that expertise is really pretty cool. Paul has 3 children, and like many of us, a bunch of them have been living with him since COVID-19, which is a great experience, I'm sure. And let me just say about Paul, when I was secretary, Paul was really of great help to me, coming and lending the expertise at Johns Hopkins University. But what's so unique about Paul is that he not only has incredible IQ, but he has EQ. He called me up one day and he said, David, look, I'm here to help, but I know everybody wants to help you. I don't want to get in your way. I'm not going to bother you and push myself to help. Just let me know if you need help and know that I'll always be there. And I think he's just a remarkable person that way. Last and certainly not least is Peter Slavin, who is the CEO of Massachusetts General Hospital. I've actually known Peter the longest of all these 3 panelists. When Peter and I first became friends in the early 90s, we were the really oddball doctors that didn't just want to practice medicine, but wanted to get involved in management. People thought there was something wrong with us. But ever since I got to know Peter, I've just watched him in awe. He really developed into an amazing executive. He became the president of MGH in 2003, and obviously has done a great job there. But what Peter, I think you'll see about him, even though he has every reason to have a big ego, he is the most humble of guys. Even when you ask him today, what is MGH's greatest achievement, and everything that he's done at MGH, built these amazing programs, he says it goes back to 1846 when MGH put the first patient to sleep in this country. So he knows that he stands on the shoulders of giants, and that's remarkable. I think the other thing to know about Peter, when you ask him about, his professional achievements, he says, look, the professional achievements I've had are the icing on the cake. The real cake is his family. And so he's a very grounded guy, and glad to call him my friend. So we're going to be talking about 3 topical areas today for the panelists. One about leadership during this unprecedented time. Secondly, what does that mean for changes to our health system and the health systems that they run, but our broader health system? And last, about innovation and what this means. And so to do that, my co-host, Stuart McLean, and I are going to sort of take you through a few questions. Think of us like sportscasters. We're going to do a little bit of back and forth to make sure that you guys are staying honest to your answers. But the first question, which I'm going to start with, is about leadership. And, health systems have really been challenged. I don't need to tell you, you guys are doing that every day. And no doubt you've had to make some really tough decisions. In fact, I've heard some leaders say that the virus, the pandemic, has actually helped them make some decisions that would have probably been too hard to have made before the virus, before they were in crisis. So tell us a little bit about what it's been like to lead your organization through crisis, and whether any of those decisions that you've had to make were hard, and what some of them were. And I'm going to start with Dr. Klasko. So welcome, Steve.
Well, thank you. First of all, I'm just thrilled to be on this panel. As an obstetrician from Allentown, getting into the lobby of either Hopkins or Mass General would have been difficult. So to be on a panel with Peter and Paul is really an honor for me. Look, I think, as you said, I don't think COVID is a game changer. I think COVID just accelerated what we already knew. That healthcare had survived, for all intents and purposes, on drugs. And I remember when I started at Jefferson, I was on a panel with Austin Goolsbee, and he said the 2 things you don't want to be running for the next 10 years are academics and healthcare, because they're clueless. And I just took a job in academic healthcare. So here's what I'd say. I think the leadership lessons for me at Jefferson, we actually started, as you know, with a 4-pillar model. I sort of took some hints from my time at Apple, where Steve Jobs recognized that even though they were a computer and a platform company, computer and platforms weren't what it was going to be about 10 years from now. It was very difficult as a leader to tell all the people that were working on computers and platforms that the new math was going to be something that didn't exist yet. At Jefferson, David, as you know, we back in 2014 started our 4-pillar model: the old math of academic and clinical, the new math of innovation and strategic partnerships, that we were going to diversify our portfolio. That's what got us to invest in telehealth as heavily we did, and the Robongos and the Teledocs of the world. So I think that if anything, the pandemic made that into sort of a, wow, that didn't make sense back in 2014. It certainly makes sense now. I think the second thing I'd say is, our colleague Mike Useem from Wharton, he gave me the best advice ever. He said, Steve, a great leader should always have 5 people under them that think they can do a better job than them, and 3 that are right. And, I think some of it is looking in the mirror and recognizing what you're really good at. In my case, it's more entrepreneurial and creative. So as you know, what I did was get some of the best operational and execution leaders in the country. I tried to get you, but Barack got you before I could.
How about the challenges that you faced during COVID and tough decisions that you might have had to make?
So, David, thanks, and thanks for having me on the panel today. This has been, for many of us, a very difficult month now. For us, probably 10 months of planning or working on COVID during the pandemic. And when you think about it, there have been a lot of tough decisions. I think when I look at how important leadership has been during this, a couple of things strike me one of which is I don't think there's ever been a more important time to be a leader in healthcare. This is very stressful. It's very hard on people. This is, especially on the front line of healthcare, where people are putting their lives on the line. They're sacrificing, they're living in hotels, they're separating from their families, undergoing just extreme and just bravery. I mean, just being on the front line. So when I think about it, the couple of things I think that has been effective for us has been a lot of communication. People have been scared and it's unknown. I mean, people are still living unknown today. And I think communicating effectively all the time, and also being out there. I mean, I've been in the hospital every day. All right, I come here every day and I walk the floor every day. I think just demonstrating a presence there for leadership has been really important. And there were some tough days there. I mean, there was, a lot of illness. But I think the point you're asking is how this has changed us. And I really think for us, we're 6 hospitals. And, as many places, we came in as a confederation, and we're leaving as a truly integrated healthcare system. This has pushed a level of integration in response to the pandemic that we couldn't have achieved in 5 or 10 years that we've been done in 5 or 10 months. I mean, just, from one communication, always, we just communicate centrally now. Every hospital can't communicate without us, cohorting patients, having our experts on Zooms every day, sharing best practices, just a range of things. I think we've integrated a great deal during this, which has been required. The other thing I'm sure Peter and Steve would talk about it too is, as Steve said, we're just accelerating change. There was going to be that anyhow, but that change is the use of technology, specifically things like tele. And I know Steve and I have been on panels where we've talked about this before, but, we went from dozens of telemedicine visits a day to, 5,700 within 2 weeks. I mean, just phenomenal advance in how we communicate with patients, and a lot of that's here to stay as long as they continue to pay us for it. So those are just a couple of things.
Paul, if I could just, I think the integration thing, David and Stuart, is really key. We had done 5 mergers with governance as currency and had real tough time having each health system think they were their own part, and they were part, to use your word, of like a federation of independent planets. When we got to the point where we had to decide that ventilators could go across, or what the ethical directives were, they abolished all of that. And for the first time, they started talking about one Jefferson, something that we think would have taken for 4 or 5 years. And then I think just to the telehealth point, I think we're also getting away from looking at telehealth. I kid around. We don't talk about telebanking. It's just that banking has gone from being 90% in the bank to a lot being sort of people-centric. And I think what Hopkins and Mass General and we are doing is taking that and getting away from the technology and into a person-centric type technology model.
I think that's really a key point. In some ways, what you and Paul are saying is that what you couldn't maybe accomplish as the CEO by mandate, this virus has really helped you do. Hey, Paul, I just remember when you were kind enough to take me around your place and you showed me this amazing sort of center where you could control all of the admissions and take a look at all the activity across your system. Did that end up being a key part of what you're talking about?
Yeah, so Dave, what we're talking about, we have a command center that we based on the Saudi Aramco command center in Durand, Saudi, where they command all the boats that are getting oil. Well, we do the same thing here to command all our patients. And yeah, I mean, Dave, every day we were cohorting, moving patients between our 6 hospitals, well, 5 because one's in Florida, but and that sort of integration, a single command center that controlled everything from distribution of PPE to ventilators, as Steve talked about. I mean, that was key, and the command center that you saw and we grew actually during it was key to our response.
Great. Hey, Peter, much like a lot of American history, so much happens and starts in Boston. I always start the COVID pandemic with that bio conference that happened in Boston, and Mass General, of course, saw some of those initial patients. So tell us what this has been like for you at Mass General leading through this. And of course, it's not over yet.
You're absolutely right, David. That Biogen conference was maybe our country's first super spreader event. And we saw patients in our emergency room who had been at that conference wanting to get testing. And that really was our first introduction to this pandemic. We had been planning months in advance, but that was our first real taste of it. I mean, it's been an extraordinary time to be in leadership at institutions like ours, to see how much our staffs got done in so little time was truly amazing. We have one medical intensive care unit that typically cares for patients with viral pneumonia at the hospital. When we hit our peak in the third week of April, we had 12 intensive care units that were operating, and it was just remarkable to see how all the movement of equipment, redeployment of staff, institution of clinical guidelines happened. And that was just one of a million different things that I can point to where people just got heroic things done seemingly overnight. The same has also been true on the research side of things. What's happened with biomedical research during this pandemic has been remarkable. We're seeing people be as productive from an academic standpoint, but with only 50% of the people in the labs as were there previously. So something just like telemedicine has transformed and COVID has transformed the delivery of care. We've also learned a ton about biomedical research going forward. Maybe the most powerful lesson for me, though, is just the connection between us and the community. We at Mass General serve some disadvantaged, largely Hispanic communities, and we noticed shortly after the pandemic began that half of our inpatients with COVID were Spanish speaking, and we worked hand in glove with the leadership of those communities to try to do everything we could to mitigate the spread of the disease within those communities, to try to provide opportunities for quarantining for people who live in crowded housing conditions, to try to distribute food to people in those communities as well. So I think that this pandemic has taught us that we are not strictly a healthcare organization. We are a health organization and need to focus much more on the community and on the social determinants of health than I think we might have ever imagined.
Wow, that's a really neat insight. And I want to come back because all three of you have really talked about some of the major changes I think that we may need to see as a result of this to act more as a health system. But before I go to that second topic about what's going to change in our healthcare system, Stuart, do you have any questions you wanted to add in about leadership of these three?
Yeah, well, Peter, you referenced the heroism of your staff. As we enter what appears to be a second phase, how are your teams ready? What is the lasting impact today on your organizations, and what do we think the next several months look like for each?
Yeah. I think that I may agree with what Paul said earlier, that this area has perhaps been the most challenging aspect of leadership during this time. I think we have a better sense as to what military leaders face when their troops are putting their lives on the line every day. That's something that we've just not been accustomed to in healthcare, and figure out ways to support the staff through this and help them with issues of childcare and many other needs they have. This has been a real challenge, but an important focus of ours. I've used the analogy recently that I think our staff and our institution is feeling a little bit like somebody who's running a marathon, has reached the 20th mile, and is told, oh, by the way, you may be actually in an Ironman triathlon, not a marathon.
Wow.
There may be much more ahead of you. I mean, here in the Boston area, we've definitely seen an uptick in cases over the last month, but we're not seeing exponential growth. We hope that the social distancing, the mask wearing, the hand hygiene, all the steps that people in this part of the country are taking, and strongly encouraged by our governor and mayors, are maybe helping keep a break on the pandemic. But we're obviously very worried and watching the numbers every day. So we've seen a slight uptick, but no sustained growth like we saw back back in the spring. I have no doubt that despite the trauma they've already been through, our staff will be ready and will do whatever it takes to care for our patients, our communities, and each other.
And Stu, part of that I think is there's an Upton Sinclair quote. It's hard to get somebody to do something when their salary depends upon them not doing it. Getting back to Peter's point about health versus healthcare, Philadelphia has 5 academic medical centers. We have one of the greatest discrepancy in life expectancies of any city in the country. So starting about 3 years ago, 25% of my incentive became reducing health disparities in Philadelphia, most of which I have no control over. But it really created a mindset and a mission of we improve lives that went beyond if you come into my hospital or you're a student at our university, you get great care or great teaching. I think if you look around the country, a lot of our websites talk about those things. But most of our CEOs get paid based on EBITDA, census to the doctors that work for me, like me. So I think some of that has to change also. It'll also get us to talk together more. The whole concept of my biggest competitor is Hospital of the University of Pennsylvania is asinine in 2020. It's like Sears saying, as long as I beat pennies, I don't have to worry about anything else back 20 years ago.
So,
I'm gonna take this as an opportunity to move us to the second topic, and I think the three of you have already sort of helped me in targeting some of the questions, because it really is once and hopefully soon the virus will be in a better situation, either with a vaccine or pandemic or monoclonal antibodies or anything else, but is healthcare going to go back to the way that it was before the pandemic, or are some of these changes permanent? And I'm going to let you guys answer that however you want, but I think, Steve, you've really talked so much about this transforming to a healthcare system without an address with using technology. Paul, you were talking about the consolidation and the integration of healthcare system, and whether you think this is going to accelerate that. Can you still have a private practice of medicine or be a community hospital? And Peter, I was fascinated you talking about the social determinants and whether, since we're not paid that way, whether this is going to be a real thing in the future, or whether we're going to see payment systems change the way they did with telehealth. So, Steve, why don't you respond any way you want about permanent changes to our system?
So look, I think it's been frustrating, during this presidential election to not see more creativity other than, how can we give more people access to a broken, fragmented, expensive, and inequitable healthcare system? So to me, I think the pandemic has proven that Bernie Sanders was 100% right about the problem, and the pandemic has proven that Bernie Sanders is 100% wrong about the solution. He was 100% right that we have an insurance-driven, corporate-driven sick care system. He gets an A for that. I think the pandemic proved, let's just leave it to the federal government and the state governments to work together to run it, is probably the wrong solution. I mean, for me, I think we're in this real nexus period of moving from, hospital-driven mentality, university-driven mentality, to one of defining Jefferson by the care and caring we give wherever it is, what we call healthcare at any address. Getting from here to there is really, really difficult if you haven't diversified your portfolio yet and you don't own an insurance company. All you have to do is look at the 3 months from February to April where the American hospital systems doing the right thing lost $500 billion. And the American insurance system, the middlemen literally reported earnings at twice what it is, what they were in 19. So, I mean, literally, there's no system on the planet where that would make as much sense as possible. We had twice as many COVID patients as any of our folks. At one point, we had about 900 patients on a daily basis in the hospital. We never used one KN95. We kept our gowns that went from 20 cents to $11, 15,000 a day. That cost us $50 or $60 million, while our primary insurers were still paying our COVID patients as a normal pneumonia because they could. So I think, we have to figure out a way how to get that alignment. We have to figure out how to diversify our portfolio. And we have to take some of those short-term hits, because nobody's going to spend on the university side $60,000 to come into our university and get a business degree at our place. I think the whole issue of heads and beds mentality is going to be different. I'd leave you with this. I think the future is, people don't view themselves as patients. 97% of the people at Jefferson, in Philadelphia, don't view themselves as patients. They view themselves as people that want to be able to thrive without any chronic disease getting in the way. If I can get them to have the Jefferson app while they're a person, and they, God forbid, get pancreatic cancer or need something, they're not going to go up and down the Schuylkill Expressway to see if Penn or Us has a better billboard. We're going to have the Jefferson app and as a healthy person, and then assume that we're the easiest one to access in that way.
I think that's great. Paul, what's your sense about what changes are going to be permanent?
I always like listening to Steve. He mentions a future that has a lot of energy around it. So when we're thinking of permanent changes, I think they're going to be, I wish Steve is right, but I hate to say it, it's going to have to do with how we change the way we pay for things. I mean, my biggest concern is, we'll probably, at the end of the day, end up with $5 trillion or $6 trillion of additional debt to the federal government. The federal government is the largest purchaser of healthcare in the country. And somehow that debt's got to get paid off. And with the discretionary part of that budget, as we all know, based on Medicare and Medicaid, the pressure on thinking through how we pay for healthcare is going to be tremendous. What we're going to see is, I think, real pressure on healthcare expenditures when this is all done. That's one thing. And, Steve, we do own an insurance company, and that was a little bit, a little help here, but I got to tell you, it didn't cover all the losses from the hospitals. So the other thing that I worry about, I actually, I agree, and Steve mentioned briefly, I think our cost structure, things like our supply chain, which was totally disrupted, is going to really change too and make it more expensive. I hate to say it, because we're not going to, I don't think anyone's going to feel comfortable relying on China for our supply chains anymore.
Yeah.
It's going to drive costs up. At the same time, we're going to have this pressure on revenues from federal spending. And we mentioned a little bit before, I do worry about the workforce. You have a lot of baby boomer nurses and physicians. And I actually think we're going to see real pressure on that workforce. I think people are going to burn out after this. And I think we need to start thinking about what the workforce is going to look like, because I think you're going to see a lot of people retiring right after this is done, and tremendous pressure on both physicians, nurses, everyone, because that baby boomers, they're 60s and they're going to get us through this. But I think you're going to see wave of retirement.
Yeah. And Paul, what about your thought if you're a standalone community hospital or in private practice of medicine? Do you see this as forcing a greater consolidation?
There's going to be huge consolidation. It'll start with physician practices, which got really hurt during this. I cannot tell you, I bet you, Peter and Steve, the number of physician practices in this area that are coming to us and be absorbed in our system. Community hospitals took huge hits here. You're going to see huge consolidation. I will say, just a plug for the three of us, I cannot think of another time where academic medicine, our capacity to absorb huge number of patients, our ability to innovate in terms of the care we provide, I think we've demonstrated our worth to the country in a way that I've in my lifetime, I think we saw it in AIDS, when I began my career, but really since AIDS, our ability to absorb, and this dwarfs AIDS, in terms of the number of patients that we're hospitalizing. And I think the country's got to think through, because there will be another pandemic in my kid's lifetime. And hopefully, I can't say hopefully not in my lifetime, because hopefully I live long enough to do that, but you never know. So I think we're going to have to understand how to pay for the capacity the academic centers demonstrated is required in our healthcare system, which is very inefficient. That's why we are expensive, because we have the capacity to absorb what we need to and innovate and then try these new therapeutics and do the research that Peter talked about that is changing the way we're treating the disease on the fly here.
Paul, and maybe you could comment a little bit, and maybe Peter will pick it up as well. You talked about the need for more consolidation. Your thoughts on the federal government's role in regulating that consolidation? And Steve, I know you'll take that one for a long while, but I want to hear from Peter as well.
I'm not a huge fan of government regulation. How about that? I'll leave it at that. I like the marketplace. So
let me be a little more subtle. The FTC is living in the 80s. I mean, as you know,
I was subtle. You're being less subtle.
I was being sarcastic. So let me just give you, this says it all. So David and I, David was the Dean of Medical College of Pennsylvania when I was the Dean at Hahnemann. It was owned by a for-profit out of Dallas that decided to close it with a day's notice, that and Eastern Pennsylvania Psychiatric Institute. Tenant's stock went up, but the poor people, the underserved people in that community really, really, really got hurt. Then Hahnemann, literally, they decide to sell Hahnemann, an 850-bed hospital, all underinsured and uninsured, right in the middle of the city. They sell it to a hedge fund guy and his wife from California. The mayor, the governor, the FTC, and the Pennsylvania Attorney General said, what could possibly go wrong with that? Everybody that had half a brain knew it was going to get sold for real estate. Miraculously, a week's notice, they sell it, 3,000 people out of a job. Again, the underserved people are hurt. The heroes were Einstein, Temple, and Jefferson that took those uninsured patients. Okay. Now the last safety net nonprofit hospital, Einstein, is really in trouble and almost bankrupt. We decide to take it over. We have spent $20 million to fight the FTC because the insurers are afraid that Jefferson might get too big and at some point have an insurance piece. The fact that the FTC lives on this model that everybody that has care goes to a hospital, and as was recently said, they ignored Penn because Penn is in West Philadelphia. The fact that they have 87 different outpatient sites in those areas that we're not even considered in the FTC thing. So yeah, we have a real problem where the insurers are immune from these kind of things, and the hospitals are being hyper-analyzed for consolidation.
I think, Steve, we're going to see you running Bernie Sanders' campaign in 4 years. Hey, Peter, we want to get you into this, and certainly you can comment on anything you think you're going to see changing permanently, but I really would like your comment on, since you feel that it's so important that we address these social determinants in our communities, do you think health systems are ever going to be paid for doing that?
I don't know exactly how that's going to happen. Certainly global payments, or David, when you and I were kids working together, capitation is probably a better way to reimburse providers and make them more focused on the health of a population and managing its costs. So I think that's a step in the right direction, but I don't think it's as potent an incentive as is ultimately going to be necessary. And I honestly don't know what that incentive would look like. But we're all nonprofit institutions. We're not. Our goal is not to generate a margin. It's really to serve the communities that created us. And I just think it's incumbent upon us to remain focused on that part of our mission. And I think we all recognize that we in healthcare can affect about 25% of the health of a population. It's poverty, education, the environment, and so many other things that affect the other 75%. And if we want to do well by our patients, we need to start getting more involved in those sorts of things, not only trying to work in coalitions in our communities to address them, but I also think using some of our advocacy clout to weigh in on issues such as poverty, gun violence, et cetera. So I think we need to, we've certainly been pushed out of our comfort zone during the last 6 or 7 months. I think we need to stay there and really more completely fulfill our responsibility to serve populations of people who depend on us.
Do you think that the pandemic's going to actually accelerate innovation?
I think if anything, David, we've seen it accelerate innovation. Our investigators have never been more productive in terms of writing grants and growing their research portfolios. They've also never pivoted so dramatically toward focusing on a single disease as we've seen over the last 7 months. We've also built within the institution infrastructure to help better support this. In the past, we would be operating or engaged in multiple clinical trials, but it was the responsibility of each investigator to encourage his or her colleagues to get their patients onto those clinical trials. Now we have a unit that was established within the Department of Medicine that screens every COVID patient that's admitted the day before, is well aware and engaged in the dozen or so clinical trials that we're involved in, and tries to assign patients, allocate patients appropriately to those studies, so that the vast majority of our COVID patients are actually participating in one trial or another. So I think there are many ways that this has stimulated a lot of positive thinking that is going to advance innovation going forward.
I think the real exciting part, David, is to be able, as we spend $1 trillion on the digital transformation of healthcare, to go from a vendor-vendee relationship to a partner relationship, right? So I'm tired of going to him as having 876 24-year-olds tell me how they're going to transform healthcare, and then having them start an IPO. As you know, we've actually partnered with General Catalyst, where they're on my cabinet. You know, in the book we wrote started out, what if a Silicon Valley entrepreneur and the CEO of an academic medical center walked into a bar, got married, and had kids? On November 2nd, we're actually creating that kid, where we're taking our whole digital innovation team from Jefferson and partnering it with General Catalyst into a NewCo.
Fascinating. Paul, what do you think?
So I think, I think both David, Stephen, and Peter talked to one of the strengths of this spurring innovation is the fact that you come at a time when many of us have transformed our data systems into ways that we can harness data in a way we didn't, and harness all the different types of data. So we have a precision medicine platform that every COVID patient was on from day one. And we've already built tools in Epic that a clinician uses at the time of admission that can predict if a patient's going to end up in the ICU or not. I mean, again, when you start a new disease, you can basically build the systems the way you want them to and really innovate. So in most ways, it's going to innovate. But on the other hand, there are some people here who I think this is inhibiting their prior innovation in areas, obviously not around COVID, but others. I worry about NIH long-term here. I think it's going to need some money to restart our non-COVID researchers. And so I think in general, it's spurring some innovation, but also going to hinder others within the system.
Okay.
Thank you, Paul. If I could, on behalf of A&M and our clients and friends here today, I want to thank you, David, and thank you, Paul and Steve and Peter, for joining us and giving us your insights today. Super valuable. Much appreciated.
Thank you.
Great.
Thank you for everything you guys do.
Good to see everyone.
Great. Thanks so much. Appreciate it.
Alvarez and Marcel. Leadership. Action. Results.